It's certainly been a challenging couple of years for all of us in healthcare, Kerry. How has COVID-19 impacted the clinical management of respiratory patients in your practice?
That's certainly true, Richard. The pandemic has presented significant and unforeseen challenges across all the health sectors. Quite early in the pandemic in 2020, we implemented changes on how we consulted with patients to reduce the risk of spread of infection to our doctors and staff and other patients. Many of our patients with chronic respiratory conditions, understandably, were very anxious about being exposed to this new coronavirus and so often avoided seeking healthcare. It soon became inevitable that we had to suspend point-of-care spirometry as the case numbers increased.
It's really important to highlight, though, that spirometry didn't become any less essential just because testing was restricted.
That's absolutely right. Patients presenting with respiratory symptoms such as breathlessness, cough or exercise intolerance still require investigation to determine a diagnosis. Our Australian asthma guidelines and COPDx guidelines still recommend spirometry as a key diagnostic tool. Being unable to do spirometry means that many patients may not have a correct diagnosis. And then there are our patients with chronic respiratory disorders such as asthma and COPD who would be having spirometry for monitoring of their disease but have been unable to access spirometry.
I think facilitating spirometry has become harder since COVID, but it's certainly not impossible. Pulmonary function testing in respiratory function laboratories has continued, but not without its challenges. I think health services will have to look carefully at the logistics before they commit to spirometry long term going forward.
We're now in 2022, still in the pandemic, but we do need to get back to doing spirometry. But we also need to keep our staff and our patients safe. It is timely that a working group of the Thoracic Society of Australia and New Zealand and the Australian New Zealand Society of Respiratory Scientists have undertaken an evidence-based review of the literature to provide guidance for performing lung function testing during COVID-19 outbreaks. This guidance is relevant to all healthcare settings, whether that be primary and community care, secondary and tertiary settings, but also occupational and research environments. The working group utilised the hierarchy of risk control, a standard occupational health and safety risk control tool, to group controls to risk mitigate against transmission of the virus that causes COVID-19. It will be up to individual practices then to determine the controls they wish to use based on the evidence to mitigate risk when performing lung function testing. Whilst they are yet to publish their full report, the preliminary guidance released in January this year has given us lots to consider. And of course, the public health and clinical landscape is rapidly evolving, as too is the evidence. So the advice may also evolve over time.
Kerry, you were on that working group. What are the implications for general practice?
There will be increased costs to practices associated with performing spirometry, buying inline filters, the additional personal protective equipment such as P2 or N95 respirators, and goggles or face shields.
So just to clarify, the P2 and the N95 particulate filter respirators can also be referred to as masks, which can cause some confusion. As opposed to surgical masks, P2 or N95 respirators require fit testing to select the most suitable respirator, must be fit or seal checked properly each time they're used, and must always be secured with head straps, not just ear loops.
We will also need to consider the extra staff time required for screening of patients to assess their infection risk and the extra cleaning required. Then there is determining whether the room in which we are performing spirometry meets the ventilation requirements to reduce the risk of infection transmission to our staff or subsequent patients being tested in that room. And of course, we need to ensure that our spirometry operators are appropriately trained and can maintain their skills.
Kerry, considering the implications you've just outlined, are there any ways that general practices can more successfully integrate spirometry into their clinics?
Practices may find it beneficial from a business perspective to incorporate spirometry testing into care planning visits for their patients with chronic respiratory diseases such as asthma and COPD. Some clinics might find it easier to have a dedicated session once or twice a week where spirometry is undertaken in a dedicated space rather than ad hoc throughout the week.
Kerry, I imagine there's lots of respiratory patients that were lost to follow-up because of the COVID restrictions imposed on health services. What strategies will you employ to reconnect with these patients?
Certainly in my practice, we have kept a list of patients due for spirometry who we intend to contact once we have our testing service up and running again, but who would have thought that we would be waiting over 2 years to recommence spirometry. We will need to somehow prioritise the patients on our recall reminder lists into those we test sooner rather than later. Those with more severe disease or those who've had exacerbations or are known to be high risk or due for care planning will be recalled first. We'll also search our electronic records for those patients who have been commenced on respiratory medicines who require confirmation of diagnosis of asthma or COPD. And I'm sure that when we search our databases, we will identify plenty of other patients who need spirometry.
While there's the potential for referring patients to the local respiratory function laboratory, we need to consider that there is often long appointment wait times in the public hospitals for patients who do not meet clinically essential criteria. In addition, COVID-19 restrictions still apply to pulmonary function testing in some labs, which may considerably delay patient appointments.
It sounds like the public respiratory labs will not necessarily be able to see our patients in a timely manner, and that is why it's so important to reintroduce spirometry to primary care.
Kerry, it's a real balancing act, isn't it? On one hand, we know that SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, is transmitted predominantly via both droplets and aerosols, and we know that spirometry generates aerosols either via the manoeuvres themselves or by inducing coughing. I would say as a respiratory scientist that at least 1 in 3 patients cough to some extent during spirometry manoeuvres. And adding to the concern is that healthcare workers conducting spirometry testing are in very close proximity to the patient for extended periods of time. On the other hand though, it's clear that spirometry continues to be an essential diagnostic and monitoring tool in the clinical management of respiratory disease. So what key messages from the TZANS ANZRIS Infection Control Working Party do general practices need to consider to make spirometry safer for patients, staff and healthcare workers?